healthcare provider. It's my pleasure to introduce Leslie Evans as our speaker for this webinar. Leslie is a board-certified clinical genetic counselor and program manager for the Pre-Implantation Genetic Diagnosis Program of the Oregon Reproductive Medicine Genomics team. She completed her bachelor's degree at DePauw University and her master's degree in genetic counseling at the University of Texas Graduate School of Biomedical Sciences at Houston. Since graduating in 2000, she's worked as a clinical genetic counselor in several specialties, including prenatal, pediatric, and cancer genetics, and she's been very involved with the National Society of Genetic Counselors throughout her career.
All right, thank you so much for the introduction, Gina. Gina is an incredible wealth of information and will be joining us for the Q&A portion of this webinar later in the hour. But first, I'd like to spend about 30 minutes or so reviewing some basic information about how genetics affects infertility. Healthcare professionals define infertility as not being able to get pregnant within 12 months or more while having unprotected sex on a regular basis. Women between the ages of 35 and 40 who have trouble conceiving after 6 months or more may also have infertility. The risk of infertility increases with age for women, and we'll discuss the reasons for that in a minute. So being infertile is a very difficult topic for individuals or couples to talk about with others. People often experience a major sense of loss or failure, and they often feel judged by others. But it's a common condition that 1 in 8 people have to deal with. This is National Infertility Awareness Week, which is aimed at uniting millions of Americans who want to remove the stigmas and barriers that stand in the way of building families. Historically, infertility has been considered mostly a female problem. We now know that male factor infertility is just as frequent as female factor infertility, each contributing to about 1/3 of all cases. Infertility from both male and female factors, as well as unknown factors, make up the last 1/3. About half of all cases of infertility are caused by genetics, not necessarily inherited, but a genetic issue nonetheless. A reproductive endocrinologist or fertility specialist is a type of medical doctor you're going to find at a fertility clinic. And he or she has advanced training in the evaluation and treatment of fertility and works as the conductor amongst a team of nurses, embryologists, psychologists, and genetic counselors to individualize and optimize your fertility care. We all work together to give you the best chance of getting pregnant and having that healthy baby. Genetic counselors are typically master's trained healthcare professionals with specialized training in medical genetics and counseling. For those patients who may have a genetic cause for their fertility issues, many reproductive endocrinologists will partner with a genetic counselor to have them explain the screening and diagnostic tests available while providing empathetic, emotional support throughout the decision-making process. When the cause of infertility is genetic, there's an issue with the chromosomes or genes. Now, you may have heard the word genome before. You can think of the genome as an instruction book used to tell your body how to grow and develop properly. Chromosomes are chapters of the book that are comprised of thousands of genes. Genes are the sentences of the instructions in each chapter. So, if a genetic counselor orders a test that looks to see if any whole chromosomes or parts of chromosomes are extra, missing, or rearranged, which would involve hundreds to thousands of genetic instructions, or we may order a test that looks at a particular gene or set of genes, which is like running a spell check on specific sentences. These are what the chromosomes in a typical cell looks like. Now, of course, it doesn't come out looking this neat. This image was created by cropping the images of each of the chromosomes and lining them up by pairs arranged by their designated numbers. It just makes it easier to look at. We have 23 pairs of chromosomes in all of our cells, with 1 chromosome in each pair coming from the egg and the other from the sperm. Having the incorrect number of chromosomes in the embryo can lead to an early miscarriage or a failure of the embryo to implant into the uterus. In fertility, we often discuss the option of doing chromosome analysis on embryos or the parents, or both the embryo and the parents. We'll talk more about some of these examples in a minute. I also want to point out that the genes are wrapped up tightly on each of these chromosomes, and we can't see if there's any changes to specific genes with chromosome testing. So those are separate tests. We often refer to changes in a gene as variants or mutations. There are many specific genetic causes of infertility, some that are specific to women, some that are specific to men, and some that can occur in either men or women. We do not have enough time to go through every single example, but I'll walk you through some of the more common examples of the genetic causes of infertility. I'll describe how we diagnose them and the fertility treatment options for that diagnosis. And Jean and I will have time to answer questions at the end of the hour to see if there's something that I didn't cover. For women, the two biggest genetic factors for infertility include maternal age, or having some sort of ovarian disorder, such as premature ovarian insufficiency or failure. For men, it's having little to no sperm count in a semen analysis, or differences in the size and shape of the sperm. When we see a couple having difficulty getting pregnant or carrying the baby to term, it can indicate a genetic issue with either the man or the woman. Recurrent miscarriage is when a couple experiences 3 or more pregnancy losses in a row before they are 20 weeks along. If a couple or individual is already working with a fertility specialist and they've not gotten pregnant after 3 tries using fertility techniques, that's called recurrent implantation failure. Now, one of the biggest causes of infertility for women is age. Women are born with their lifetime egg supply, which is about 400,000 eggs. As we get older, the number of eggs steadily depletes as we reach menopause. At menopause, which happens on average between the ages of 51, 52, we have very few eggs left in the ovary, and of those eggs, they're of very poor quality as well. So not only does the egg quantity decline with age, but egg quality declines as well. And poor egg quality means poor embryo quality after fertilization. The big genetic factor that determines egg quality is having the correct number of chromosomes. As a woman gets older, there's more of a chance for her egg to have an extra or missing chromosome. This results in an embryo with an incorrect number of chromosomes. It's also possible for the sperm to have extra or missing chromosomes, but men are constantly remaking sperm. So aging doesn't have the same impact on the sperm's chromosome as it does for the eggs. So this is the data we use to educate patients at our fertility clinic. Egg donors are about 25 years of age on average, and you can see as the mother's age increases, the number of chromosomally normal eggs decreases. So 25, you've got a 61% of your eggs that are chromosomally normal, but that percentage is reduced to 18 as you reach 41 or 42. So if we have a 42-year-old woman who's having trouble getting pregnant, and there's no other reason we'd suspect for her to have an issue other than her age, we'd offer her in vitro fertilization with comprehensive chromosome screening. This involves analyzing the chromosomes of her fertilized eggs, which are the embryos. The process starts with in vitro fertilization, or IVF. It's actually a really common procedure involved in other fertility techniques as well. We'll talk about IVF in terms of cycles. Cycle starts when women start taking medication to stimulate egg development. We want to have as many eggs to work with as possible to increase our chance of having a genetically normal embryo to transfer into the uterus. The eggs are retrieved through an outpatient procedure performed by the reproductive endocrinologist. Next, the eggs are fertilized by an embryologist in a very sterile and temperature-controlled lab. The legs grow and develop in the culture for several days, and then one or two of the best-looking eggs are transferred into the uterus. If an individual or couple chooses to do comprehensive chromosome screening, or CCS, we do that test in between these two steps here. You may also see or hear comprehensive chromosome screening referred to as pre-implantation genetic screening. It's the same thing. Unfortunately, we can't analyze the chromosomes of an egg without destroying it. So we have to fertilize an egg to make an embryo. We then need to give it some time to make enough cells so that we can remove some of them without hurting the embryo, and then analyze the chromosomes of the biopsied cells to see if the embryo has the correct number. So this is a video of an embryo biopsy, which is done in the fertility clinic's lab. When an embryo is about 5 days old, it's made up of about 100 cells. The embryologist will watch the embryo under a microscope. It holds the embryo in place with a small pipette that has a small amount of vacuum, which you see here. And about 5 to 10 of the cells are removed from the future placental cells of the embryo using a small laser and another pipette with some pressure to pull those cells away. The inner cell mass here, these go on to form the fetal cells and they remained untouched. So let me play the video here so that you can see this in action. So here are the biopsied cells. You can see this red dot in the middle here. This is going to be the laser that's going to start working its way through the cells to cleave off those 5 to 10 cells that'll make up the biopsy. And there you go, there you have it. And so the biopsy cells are sent to the lab. This is the remaining embryo, which is frozen until we get the results back in 1 to 2 weeks. We discussed the results of the chromosome testing with a patient or couple. There may be several chromosomally normal embryos to choose from that look like they're growing well. 1 or 2 of them can be transferred into the uterus at the fertility clinic, and the others frozen for a later use. Or there may not be any chromosomally normal embryos, and the patient or couple need to decide if they want to undergo another IVF cycle or choose a different strategy like using an egg donor or adoption. So CCS is a technique that is not only used for women with advanced maternal age, but can also be used in situations where there have been recurrent miscarriages or implantation failures, or if the parent has a known difference in their own chromosomes, which we're going to talk about next. A patient or couple may elect to have CCS performed for personal reasons, especially if IVF is part of their fertility treatment anyway. Remember, we said that a woman around age 25 has about 61% of her eggs chromosomally normal, but that means that 39% are abnormal even at such a young age. So there's actually no standard recommendation from the American Society of Reproductive Medicine, or ASRM, for when fertility clinics should offer CCS. There is some controversy among reproductive endocrinologists about offering CCS to patients so liberally. Some are being conservative because they want to see more data, or they want a direct recommendation from ASRM. Now, the vast majority of embryos do well with the biopsy procedure in the hands of an experienced embryologist, and the success rates for getting pregnant after are really dependent on the IVF success rates for the fertility clinic. There also has not been a conclusive study on any potential long-term effects of the biopsy on the embryo, but the majority of the IVF community believe the procedure to be safe at this point. So we've discussed maternal age. Next, we're going to discuss what we do for patients experiencing one of these other causes of infertility. One of the first tests we would offer in any of these situations is doing chromosome studies on one or both of the parents. Sometimes it's the parent who has the extra or missing chromosome. And this can lead to abnormal egg or sperm production, anatomical changes in the ovaries or testes, and hormonal changes that make it difficult to get pregnant naturally. For women with an ovarian disorder, we may find that they have Turner syndrome, for example. So Turner syndrome is a condition where women are missing all or part of the chromosomes that determine sex. In the most severe form, they have 45 total chromosomes and only 1 X chromosome. This condition occurs in about 1 in 2,500 female births. They can have physical characteristics such as being shorter than average and differences in how their heart and other organs are formed, which could shorten their lifespan. Sometimes women with Turner syndrome don't receive a diagnosis until they're teenagers, or they try and have children. So spontaneous pregnancy only occurs in about 2 to 4%. They may not produce eggs at all, or have premature ovarian insufficiency, which is also referred to as premature ovarian failure. And that's when there's a loss of normal ovarian function prior to the age of 40 caused by producing low levels of estrogen. So many women with Turner syndrome can get pregnant with the help of a reproductive endocrinologist, however. They may be good candidates for hormone treatment and IVF. And we also discussed CCS because there's a higher likelihood of having embryos with abnormal chromosomes. They may elect to do egg freezing because of the premature ovarian insufficiency as well. And with this option, she would also undergo IVF. Then we'd cryopreserve the retrieved eggs and keep them cryopreserved until she's ready to use them. If having a biological child is not a great option, they can choose an egg donor and transfer the embryo into their uterus. If they do get pregnant, she needs to be followed closely by a high-risk OB because there's a higher likelihood for her to have a fatal heart complication because of her condition. In addition to personal health risks, women with Turner syndrome have a higher miscarriage rate and may have to use a surrogate. All right, an example for men who have low to no sperm count, we may find that they have Klinefelter syndrome, which occurs in about 1 in every 500 to 1,000 males. So this is a condition caused by an extra X chromosome. So they have 47 chromosomes with the sex chromosomes designated as XXY instead of 46XY in a typical male. The men with Klinefelter syndrome have small testes and don't produce enough testosterone. Low testosterone leads to delayed or incomplete puberty and infertility. Some males undergo testosterone therapy to trigger that puberty. And it's not unusual for men to first learn that they have this condition when they try and have children or get an infertility workup. So Klinefelter syndrome is the leading cause of infertility in men, affecting about 3%. For men with Klinefelter syndrome or some other condition that causes low to no sperm count, we'd offer a procedure called testicular sperm extraction, or TESE, which involves extracting viable sperm cells from testicular tissue via biopsy. The next step is to fertilize an egg with an extracted sperm cell in a procedure called intraplasmic sperm injection, or ICSI. The embryologist holds the egg, so here's the egg here, again with a pipette with a little bit of suction. And then what we do is he or she injects a needle into that egg cell and transfers a single sperm. And hopefully this union will result in an embryo which can be transferred into a uterus. So let's play this. So you can see here in a minute, there's the sperm, a single sperm, and then they pierce the egg, pipette up and down to release that single sperm into that egg. And that's it. Hopefully magic is happening. And then if that embryo does take and grow and develop, then we can transfer that into the uterus. So of course, ICSI is also using the IVF procedure that we talked about. Because men with Klinefelter syndrome have an increased risk for having a child with an incorrect number of chromosomes, they may also elect to have CCS performed on the embryo prior to transfer, which we've already discussed. Affected men may also elect to bank their sperm, which involves freezing the sperm for later use, especially if they're about to undergo testosterone therapy, which could further compromise their fertility. And of course, they could also use a sperm donor. For couples who've experienced recurrent miscarriages or implantation failures, we would order chromosomes on both parents. But we may find that one of the parents has a chromosome rearrangement. There are two kinds of rearrangement. Translocations are caused when pieces of genetic material break off from two different chromosomes and swap places. Or it can also be caused when two chromosomes join together to form one large chromosome, like in this case where we've got chromosome 14 has attached itself onto the top of chromosome 13. So translocations are balanced when they don't compromise the amount of genetic material for the person who carries them, but they do cause an increased risk for creating embryos with the incorrect chromosome number or structure. Another type of chromosome rearrangement is an inversion, where the chromosome segment is rearranged end to end on a chromosome from which it comes from. So it's just like flipped. Theoretically, inversion should have the same number of genetic material in the chromosome, but it just has it in a different order. So while an inversion is generally considered to have no harmful effects for the parent who carries it, it could lead to an increased risk for miscarriage or infertility for some individuals. Individuals with chromosome rearrangements can elect to do IVF and then proceed to pre-implantation genetic diagnosis, or PGD. It's mostly the same process as IVF with CCS described earlier. So IVF is performed to fertilize the embryos in the lab, and then a biopsy is performed on the embryo and the sample sent to genetics lab. But the technology used to detect a chromosome rearrangement can vary depending on the type of rearrangement to be analyzed. Also, the parents can elect to have CCS performed at the same time on the same sample that's used for PGD, so there's no need for a second biopsy on the embryo. Lastly, couples can choose an egg or sperm donor in these situations as well. All right, we've been talking about fertility issues derived at the chromosome level. And next I'm going to talk about, I'm going to end with male and female example that involve changes at the gene level. So there are only a handful of genes known to cause or be strongly associated with infertility. But there are likely many, many more that play a role, which we learn more and more about as this field evolves. The most common genetic test ordered in probably every fertility clinic throughout the US is probably carrier screening. The Committee on Genetics for the American College of Obstetrics and Gynecology recommends that all patients who are considering pregnancy should be offered carrier screening for a minimum number of disorders. Carrier screening can be done via saliva or blood test. Now, the main purpose of carrier screening is to see if you and your partner carry a genetic mutation that can cause an increased chance to have a baby with a serious genetic disorder. But from time to time, we get a result back on a patient that explains why they're having the fertility problems. So here's an example. Cystic fibrosis, or CF, is one of those conditions that's recommended to be on all carrier screening panels in the US. CF is caused by inheriting two non-working copies of the CFTR gene, one from mom, one from dad. This disease leads to a number of symptoms, including severe breathing and digestive system issues. And nearly all men with CF are infertile because the tube called the vas deferens, which connects the testes and the prostate gland, is either blocked with mucus or it's missing entirely. So this condition is called congenital absence of the vas deferens, or CAVD. And people with CF typically know they have the disease and are educated about the fertility issues it can cause. However, there are also variants that men can inherit that don't cause full-blown CF with the respiratory and digestive systems, but they can have CAVD related to those variants. And we may discover the infertility cause when we get the CF carrier screening back. We've gone over almost all these tests already. If a male with CF has CAVD, we'd need to do TESE to extract the sperm. Now, if the sperm had normal motility, we may not need to do ICSI, but many men in this situation, we need to do that for. Now, if the male CF variants were identified with carrier screening, chances are his female partner or egg donor also had carrier screening for CF. Again, CF is caused by inheriting a variant in the CFTR gene from both parents. So, if the male has CF, he has a 100% chance of passing on a CF variant. CF carriers are relatively common, especially among certain ethnic groups. If his partner is also a carrier, then they have an increased risk of having a child with CF. If she is positive for a CF variant, they can elect to do IVF, screen embryos via PGD, which I mentioned previously, and only transfer the unaffected embryos. However, PGD for single gene disorders like CF is a bit more complicated than it is for the chromosome rearrangements. It involves designing molecular signals called probes that can help the lab distinguish which embryos have normal versus abnormal genes for CF. These probes have to be individually designed for each person by using DNA samples from family members like their parents, and takes several months to complete. So it can be done, but it's not an easy process. Here's another example that applies to women. So Fragile X syndrome is not necessarily recommended for women who don't have a family history of Fragile X related disorder, but it's included in a lot of the various screening panels that fertility clinics may use. It's estimated that about 1 in 200 females has a genetic change in a gene on the X chromosome that makes them carriers for a Fragile X related disorder. Some Fragile X carriers are at risk for developing premature ovarian insufficiency, which we talked about with Turner syndrome previously. And in fact, Fragile X carriers account for about 4 to 6% of all cases of premature ovarian insufficiency. Because of that risk for premature ovarian insufficiency, Fragile X carriers may opt to freeze their eggs, which we've talked about earlier. Another option for them that doesn't have a lot to do with infertility per se is doing IVF with PGD specific for Fragile X syndrome. In addition to fertility issues, women who are Fragile X carriers may have an increased chance to have a child with Fragile X syndrome, which is the most common form of inherited developmental disability. The inheritance of Fragile X syndrome is complicated, and I'm not going to get into that right now, but we can do PGD on the embryo and only transfer embryos that receive the normal X chromosome from mom. Of course, using an egg donor is always an option as well. Again, 50% of infertility have genetic causes. If you are someone who believes you need help with fertility, I highly recommend that you work with a fertility clinic who employs or at least partners with a genetic counselor available to help you through this process. Chances are pretty good you could benefit from having a genetic counselor available to talk to. I gave you a brief overview of some of the genetic factors that can lead to infertility. Some of the answers are derived relatively easy, and others are very complicated. Genetic counselors have the specialized training to give you empathetic and thorough care for the genetics part of your workup. We can explain tests and help with decision making, order appropriate tests and explain those results. We can also screen for additional diseases by constructing a family tree or family pedigree and look for other conditions such as hereditary breast and ovarian cancer syndrome or Huntington's disease that we could also do PGD for as well. We also do egg donor screening with a family tree and also a carrier screening, and we can also connect you to additional support. I just wanted to end with this. When it seems like everyone around you are having babies, it's normal to feel like you're the only one struggling to get pregnant. You are not alone, and there is support available to you. For more information about National Infertility Awareness Week, you can go to infertilityawareness.org, and I'm going to end there. Thank you very much. And now Gina and I can take any questions. We just want to remind everyone by submitting a question, you're consenting to the information contained in the question to be read out loud at this point, and please don't submit any personal identifiers in your submission. So Gina, do we have any questions that came through?
Yes, we do. And just feel free to add in more in the chat box at the bottom. But one question that we have is, if the couple has a genetic mutation, such as BRCA1 or 2, which is a cause of hereditary breast cancer, would they test the embryo cells from the CCS testing for this mutation?
That is a great question. And we talked about the difference between CCS and PGD. So CCS is actually looking at the chromosomes, and PGD is looking at the specific genes. So since hereditary breast and ovarian cancer is a single gene disorder, we'd have to do PGD and actually design the probes in that case for the individual test. So these aren't out-of-the-box tests that we can order. We'd biopsy the embryo, send it to the lab, and we'd get with the patient to collect samples on family members, such as parents as well, to help us design those probes. Because we're not actually testing the mutation directly, but we're looking at the probes which are associated with the mutation itself that segregate with that mutation. So it takes several months to get those results back, but hereditary breast and ovarian cancer is one of those disorders that we actually has been done very successfully among fertility clinics for PGD.
And I'll just add to that, when you're doing the biopsy of the embryos, the cells that you're using for the CCS testing would be the same cells you'd use for PGD. So you don't have to do a second biopsy or take more cells. It's just basically you take the same amount of cells and then you would try to amplify the amount of DNA you're getting from those same 5 to 10 cells.
Right, so you do have the option of doing both. It's like a 2-for-1 special biopsy. You can do CCS and PGD if it's necessary.
And just give a minute if anyone has other questions to type in. So another question would just be, so if the embryo comes back from CCS as having abnormal results, then what would that mean for the embryo if you transferred it?
So we typically, we wouldn't transfer an embryo that has an abnormal number of chromosomes if it's something that we know to cause increased chance for that embryo not to implant, or if it can increase the chance for like a condition like Down syndrome. So the embryos that come back positive for a chromosome difference end up being destroyed. And so we would only implant those embryos that have the normal amount of chromosomes. Did you want to add anything? Are there some special situations where you might make an exception?
No, I mean, with the abnormal embryos, most often those embryos are not viable. So they're typically not compatible with life, which would mean that if we transferred them, they would either not implant or they would miscarry. And it's only about 10% of the embryos that we would come back with an abnormal result that could still result in a baby with certain health problems. And there is kind of a gray zone of embryos that are clearly abnormal, embryos that are normal, and then there's a gray zone of embryos that are in the middle, and those ones there is a bit more questions about, which I won't get into right now, but those ones are typically kept by the IVF clinic, but most clinics still aren't transferring them. Another question we have is, what is the current consensus of selecting for disabled embryos, example, in deaf families? So some families that have a genetic cause of deafness would like to do PGD, where they would select an embryo that is also deaf.
So I haven't had one of those cases personally. Gina, what's been your experience?
I haven't personally worked with a couple that was doing that either. I think it's a controversial topic in some ways because typically we're using PGD to select for embryos that don't have genetic changes, and in this case you would be selecting the ones that do. You know, I think it would really depend on the independent fertility clinic and the genetic counselor that you're working with. And I don't think there really is a consensus throughout all of the fertility clinics in the country as far as what different clinics would do, although I'm sure there are many clinics that would for patients that are well informed about their decisions. Another question we have is whether there's a tolerable level of mosaicism for chromosome aneuploidies in embryos. So mosaicism are those gray embryos that I was talking about, where there is basically, when you do the embryo biopsy, there are some normal cells present as well as some abnormal cells present. And the level of mosaicism depends on how many normal cells there are compared to how many abnormal cells there are. So say if you looked at 10 cells, if 2 of the cells are normal and 8 are abnormal, then the mosaicism level is 80%, which is pretty high. In general, what most labs consider is that up to 20% mosaicism level, so in 10 cells, if 2 are abnormal, that they would classify that embryo as being normal, because it's most likely that the embryo is just made up of mostly normal cells. And then embryos that have over 80% mosaicism, so over 80% of the cells were abnormal, are typically just classified as being abnormal. In between 20 and 80%, there is less consensus about what that means. There have been 1 or 2 studies that found that embryos with a lower level, like around maybe 40% or lower of abnormal cells, could still result in a healthy baby. But really haven't been very many studies done yet, and there haven't been enough babies born from mosaic embryos for us to know for sure what a tolerable level would be. And it's also complicated because the level of mosaicism in the biopsy sample doesn't necessarily reflect the whole embryo. So in the sample that you took, if the mosaicism level was 40%, it doesn't necessarily mean the whole embryo was 40% as well. So it does get a bit complicated when you're trying to decide what is the level when you could transfer mosaic embryos or not.
In my understanding too, this is a pretty controversial topic among different fertility clinics as to what they would consider to be a tolerable level of mosaicism for their clinic as well. So this is a topic of much debate that we talk about in our clinic, I think probably on a monthly basis, don't we, Gina?
Yeah, we're always talking about it because it's, you know, it's one of these things where there's evolving research all the time and there's new papers that get published, and mosaicism has really only been around for the last few years, and because of that there haven't been very many transfers yet. And as time goes on, as more and more transfers are done, then we'll get to have more information about what that means if you transfer those mosaic embryos, but it's still a little bit limited right now. Okay, and then the next question is, what is the current consensus of transferring carrier embryos for genetic condition? Is it discussed with the family? What if the carrier status can have health implications? So say if it's a carrier for something like cystic fibrosis, where maybe there's some minor health issues like the congenital absence of the vas deferens.
Yeah, as long as it's not something that is life-threatening or causes like severe learning problems or birth defects. I mean, that is something that we would discuss with the family, and it's an option that they could choose to do. I mean, the same thing, we come across that with Fragile X syndrome as well. So there might be a carrier female that has infertility problems down the road, and you know, they can, if they have other embryos, they could choose to implant one that is not a carrier for Fragile X, but they may not have that option. So again, yeah, that's something that we would talk about with the family and help that with that decision-making process. Do you have anything to add, Gina?
Yeah, I think for the most part, you would only know if an embryo is a carrier for genetic condition if you were actually doing PGD. So if the couple was actually at risk of having an affected embryo. Often we do carrier screening and we find out that one of the parents is a carrier, but the other isn't. And in that case, we would know that the embryo is at risk of being a carrier for that disease, but we typically wouldn't do PGD and test the embryo just to find out the carrier status. So it's a bit different. Like if you find out about it in the context of PGD, or if you just know there's a chance the embryo might be a carrier based on your own carrier status, we typically wouldn't have that information to discuss with the family because we wouldn't be testing them for that. And then the next question is, if an embryo is mosaic but is low enough to be considered normal, is the patient made aware of the possibility of a mosaic condition? So typically the labs basically just report out if an embryo has less than 20% of abnormal cells, they will just report that embryo as being normal. So that embryo is never considered to be anything but normal, and the fertility clinic would likely never know what the percentage was of abnormal cells there. So it's only if the embryo had that over 20%, or it can vary. So different labs use different cutoffs for mosaicism, and it really depends on which lab your clinic is using. So if the lab reports back that the embryo is mosaic, then definitely the patient should be made aware of that and be let know that the mosaicism is present. But it's kind of up to the lab and how they report the information. So, you know, from the lab that we use, if an embryo has less than 20% mosaicism, then all we'll know is that embryo is being reported as normal.
Geez, these are advanced questions. I feel like maybe I made the talk too basic.
And then next question is, do you always recommend a follow-up CVS, which is chorionic villus sampling, or amniocentesis? And if so, is doing amniocentesis better than CVS? So when we're doing this type of testing on embryos, if we're doing CCS or PGS testing, the accuracy of the testing is usually not 100%. So even if the embryo has a normal chromosome result from that testing, there could still be a small chance that the embryo has a chromosome condition. And because of that, we do always recommend that patients could have follow-up testing during a pregnancy to confirm their CCS results, even though the risk will be much lower than it would have been if they hadn't already had that screening done. Typically, we recommend that amniocentesis is the main test that's done for CCS testing. The main reason for that is that when you do CVS testing and amniocentesis, there is a small risk for miscarriage for both procedures. Typically, the risk for miscarriage has been quoted at about maybe 0.5 to 1% for CVS, and then between 0.2 to 0.5% for amniocentesis. So both tests are perfectly fine for follow-up. CVS testing does occasionally get back a result that ends up having to be confirmed by an amniocentesis later on. There's just a little bit higher chance that you'll get back a little bit of an uncertain result. So for some people, amniocentesis is the easier test just to prevent that from happening, but CVS is also done earlier in pregnancy, so it can be done usually around 12 to 14 weeks, whereas amniocentesis can't be done until about 16 weeks of pregnancy. I'll also say there's other tests that can be done during pregnancy now, screening for chromosome conditions like Down syndrome. For example, there's a blood test that can be done that screens for Down syndrome and a few other chromosome conditions, and it's got a lot of different names, but the main one is cell-free fetal DNA testing. And it's a really good screening test in just spontaneous pregnancies. And lots of patients that do CCS or PGS testing still end up having a blood test like that done in pregnancy. The one complicating thing is that they're both screening tests that are testing cells that originated from the placenta. And so there is a small chance that both CCS testing and that blood test screening could be missing something. So it's not the most accurate screening option. So amniocentesis is kind of the most accurate you can get for prenatal testing, but I do think a lot of patients end up having that blood test done as well, just because there isn't any risks when you have the test done. And then another question is, how often do you see that CCS and amniocentesis tests do not come back with the same results? Is it fairly common? It's not overly common, but it can happen. So the accuracy of the CCS testing, we usually would say it's over 95%. So it's unlikely that you would have a discordant CCS and amniocentesis result, but it can happen even for things like the sex of the baby. So if CCS diagnosed that the embryo was female, it's possible that you could have an amniocentesis and the CCS result could have been wrong, although it doesn't happen very often. I certainly wouldn't say it's common, but it is possible, and we do talk about that with any patient that's going to be having CCS. So I guess just maybe the last question, there's another question here. Is the chance for confined placental mosaicism higher or lower at the time of biopsy compared to the time for CVS and amniocentesis? So confined placental mosaicism basically means that the mixture of normal and abnormal cells is only present in the placental tissue and isn't present in the cells that will make up the baby. And it's more common for us to see embryos that are mosaic than it is to see mosaic embryos or confined placental mosaicism at the time of CVS. So in embryos, up to 20% come back with a mosaic result. But if we were doing testing at CVS, where we're testing the placenta, it's about 1 to 2% of those results would come back mosaic. So you can see that it's a lot more common for us to find that in embryos than it is at the time of CVS. When we find mosaicism during CVS, about 87% of the time, it's confined placental mosaicism. So most often, it's just confined to the placenta, and the cells that are making up the baby are actually normal. At amniocentesis, mosaicism is a lot less common, so you only see it in about 1 in 1,000 amniocentesis samples. So you can see that it gets less frequent throughout the pregnancy. Maybe just end with last question for Leslie. How would someone go about getting referred to a genetic counselor to talk about fertility-related issues?
So that's a great question. There are a handful of us that do specialize in fertility genetics, and some of us are employed by a fertility clinic. Other fertility clinics might contract with a genetic counselor that maybe does like prenatal counseling in the town, as well as, you know, a couple of days a week coming to the fertility clinic to see their patients. The other option is to work with a telehealth service. So there's a number of telegenetic services that have genetic counselors licensed all over the United States that can do like a phone call with you or a video call with you in order to review any questions that you have. At our place, usually when people come to us, they usually start with talking to the reproductive endocrinologist first, and then they are seen by a genetic counselor down the road. But certainly if you wanted to talk to a genetic counselor first, like in the example where you know you have hereditary breast and ovarian cancer syndrome and you wanted to discuss PGD, then you can work with a genetic counselor directly to answer some basic questions about that process. And the National Society of Genetic Counselors website, which is nsgc.org, they have a database full of genetic counselors that you can search by zip code that are local. And they also have information on telehealth genetic services as well in your area.
Yeah, and then there's NSGC also hosts a website that's just called findageneticcounselor.com, where you can put in your information and find a local genetic counselor. Great. Well, I don't think there's any other questions now. So thank you so much for presenting, Leslie. That was great.
Well, thank you, Gina, for helping with the Q&A.
All right. Thanks, everyone, for attending.
Thank you.